So let's talk about some of these targets. I mean, clearly we would like the blood pressure to be normal, the glucose to be normal. We'd like the lipids to be normal. What does the AHA and the AACE really say about targets? What are we shooting for? Let's talk about glycemic control first.
Well, I think the AHA and the ACC will have different perspective on glycemic targets.
Well, that's really helpful.
No, well, let me explain to you why. Because what we are interested in is the cardiovascular milieu, and we know that hypoglycemia is terrible for the cardiovascular system. You start to activate all the same systems we try to block all the time, like the sympathetic nervous system.
But I read that when I was in medical school. High blood sugar, bad. Heart bad, lots of things bad. What's new?
Because the AHA and the ACC have been less focused on glycemia and more on things like lipids and blood pressure.
Okay.
But you can give me your perspective.
Well, again, it's individualizing the patient and obviously risk stratification. But we still use, ACE does use hard targets in terms of blood pressure, ideal blood pressure, within that framework of individualizing.
All right, but let's focus first on sugar, then I want to transition to blood pressure. How tight do you keep blood pressure, glycemic controls here?
I'm happy at 7.
And you're looking at an A1C of 7.
A 7.
But what about blood sugar? Where do you want it? How tight should you be?
That's a very good point, because A1C is a very crude measure of actual blood sugar. What ends up happening is you can have two people with an A1C of 7, one that has vast fluctuations that causes oxidative stress that results in significant hypoglycemia. So recognizing that an A1C of 7 isn't really, quote, normal. A1C, a person who is as a non-diabetic has A1Cs between 4.5 and 5.5. So there are more aggressive targets for younger people. For older people, I think we're not quite as aggressive because hypoglycemia becomes a greater risk. So I'm frankly comfortable with a 7.5.
And I think this is very much like lipids, because we know that a lot of the atherosclerosis is probably occurring in these diabetic patients at hemoglobin A1Cs before 7, even when they're in pre-diabetic phase. And so we know that's abnormal glucose metabolism. And so certainly being aggressive in getting the best glucose management you can would help these patients long term. The problem is, what is their risk of hypoglycemia? So I think being aggressive to less than 7, whether you're targeting 6.5%, if you can get away with that in a patient who's at low risk of hypoglycemia, great. With lipids, because the medications are relatively safe, we're finding that by stacking therapy, we can be very aggressive in lipid management. Absolutely. That helps patients. The same thing's probably true in diabetics. It's just that you're going to pay a cost if you try to push too hard for patients who are at risk for hypoglycemia, because as you said, if they're then having serious hypoglycemic events, that's probably worse than allowing them to ride a 7 or 8.
It's associated with MACE. So,
And we still have to we have to acknowledge that the pivotal clinical trial showing that getting to an A1C of less than 7 reduces mortality or cardiovascular events hasn't been done yet. Well, it has been done and it hasn't worked.
There have been landmark studies intending to bring the A1C below 7, 6.5, and even 6, but the results have not proven more.
And we're going to get to that. So younger patients versus older ones with multiple comorbidities, if I understood you correctly, a little looser in the older patients than in the younger ones?
Yeah, well, the ADA guidelines really talk about individualizing the approach. And so patients who are elderly, particularly if they have comorbidities where they're at risk for the hypoglycemia or heart problems, then I think in that situation you don't need to be at 7, because those patients may be more at risk by the hypoglycemia.
All right. Blood pressure goals, where do we want to be? Is everybody going to be 120 over 80 or better? Or even lower?
So again, I think we have to remember exactly what everyone on this panel has said. There's always a price to pay. There's no free lunch. You can shoot to lower and lower targets, but you're going to pay a penalty in hypoglycemia or hypotension or falling or whatever. So you have to individualize this as well. And I know from the SPRINT data that excluded patients with diabetes, that in certain high-risk individuals, getting to a blood pressure of less than 120 is better than less than 140. But again, the SPRINT trial excluded patients with diabetes.
I mean, the question is there any reason to believe diabetics are different? And probably the answer is there's a lot of reasons to believe that they're different.
Right, and the Accord blood pressure trial, which did the
Right.
same thing, did not
Did
show
not.
benefit, but it was a much smaller study and it did a 2x2 factorial, so there was a lot of reasons why maybe it didn't show benefit.
Is there any agreement on lipid goals? Where do you want the lipids? Where do you want LDL?
I think there's not agreement about
No,
lipid
there's
goals.
no agreement.
Even if we're talking
There's
about
no
lipids,
agreement.
That's
forget
There's
about
no
diabetics.
agreement. There's no.
So interestingly though, even though the 2013 ACC/AHA guidelines and the ADA guidelines look very differently, if you look at a standard middle-aged sort of intermediate to high-risk patient, they end up at the same place, at
Okay.
high-intensity statin.
High-intensity
Where you get
statins.
differences is if you end up start with a lower-risk patient.
So let me just, I know that because I just listened, that there's no agreement. Let's see if we can find some agreement, if you will. An LDL cholesterol of 190, bad.
Terrible.
Absolutely.
Terrible.
No,
120
nobody
in
will
a
argue.
diabetic. Not so great. Now we're getting down to 80 on a statin.
But I
with-
think to Carol's point is you shouldn't measure a LDL in a diabetic patient to trigger your decision about managing. You should say, they're a diabetic, I'm going to give them, say, a high-intensity statin, and then if you want to add on other therapies, then I think it's reasonable to say what your LDL is. But don't ever say, well, their LDL is 69, they're diabetic, I'm not going to prescribe them a
But
statin. That would
see
be
that's,
wrong.
that's where the
Agree.
confusion exists, because you're giving a statin for an LDL of 40, which is fine, I'll accept that. But then so Peter's question about target, so when do you add something like ezetimibe or something like that, if the patient is at 69 and Carol wants to get them down to 0. So what?
No, but wait. If I can summarize what you said, because I found that really profound. You're
Well,
not
thank you,
looking at well, you're welcome. You're not giving a statin to a number.
Right.
You're giving the statin to a person at risk.
Right. Exactly,
So
you're exactly
the
right.
diagnosis of diabetes, a priori, statin. That's it.
Yes.
Yes.
Now we'll argue about a number.
Right, and if you want to
Correct.
measure
Right.
it
And
to
actually,
help
I
you
think-
modify.
Even though at face value, it looks like we disagree, we don't.
Yeah,
Because
I
we do believe that you have to stratify risk. However, at ACE, we do like to see some numbers attached to that goal. Again,
But in other
do we
words-
know how low?
We don't.
We
so we
don't.
can make up a number, but
Right,
again, we
right,
don't
right,
know.
right.
If I were to put you into a clinical situation where you could not get LDL readings, LDL numbers, but you could know you had diabetic patients, you'd start them on statins.
I would, and I
Absolutely.
would say,
Absolutely.
Because it's irrelevant.
Absolutely.
No
yeah,
question.
and I would say with the numbers, why this is important to treat the patient and the risk is although there's never been a trial to target a number for cholesterol alone, if you look at any trial, whether it's statin trials, PCSK9 inhibitor trials, if you look at the lower the LDL achieved, those patients do better. And so if you end up with an LDL of 30, you do better than someone who ended up with an LDL of 50. Now, it's not randomized, but we know diabetes is such a potent cardiovascular risk factor. They need to be on a statin. And if their LDL is 40 after high-intensity statin, great. They're going to do better than a patient whose LDL is still at 120, 130, and we might want to do additional therapies, but they need to be on a statin because regardless of what their LDL is, they're at increased risk.
So I think the other point, though, is okay, so you've got the person on a statin, high-intensity statin, and their LDL, even though we accidentally measured it, was 105. Do you then add ezetimibe or something else, or do you basically say, so that was my question.
Mm-hmm.
So you do, in a way, have a target. You want to get below 70, potentially, in a patient. Carol doesn't
I
agree.
do. I totally agree. We actually wrote a scientific statement from the ACC on this because in the cholesterol guidelines, we were intentionally vague about add-on therapy because at the time that we published them, there were zero
Yeah,
trials that
pre-improved,
showed
But-
any improvement by adding additional therapy.